When it comes down to taking care of someone either in a rapid response, someone who has a pulse, or in a code, what you're going to realize is there's actually not that many things you have to choose from. It becomes more about herding the cats. That is, getting the people in your group to do what they need to do and less about the medicine. So I want to show you how simple this can be. We're going to start off with the thing that's actually harder. That's the rapid response. That is, what do you do when someone has a pulse? The first thing you want to ask is there an arrhythmia? There are 3 rhythms that are not arrhythmias. I'm going to argue for 2. The first, sinus tach. It's sinus tach. So it's fast because there's an underlying physiologic response. The sinus tach is in response to something else. Normal sinus rhythm and sinus brady. And I'm going to make the argument that sinus brady is not an arrhythmia. That is, it is an arrhythmia. Remember, in a rapid response, you've been called for something. The person has a physiologic stressor, so the heart rate should be elevated. Now, of course, the exception to this is someone who calls you with a low heart rate. That's it. If they're asleep, no big deal. But every once in a while, I want you to consider that sinus brady is indeed an arrhythmia that needs to be addressed. For the sake of this discussion, since we're talking about ACLS, there will be an arrhythmia. That is, it's not these rhythms. If it is an arrhythmia, the next question you have to ask is it symptomatic? Because if it's not symptomatic, you don't have to do anything about it. And do nothing in this case means IV, O2, monitor. Both place them on telemetry, so you monitor the bad rhythm, and monitor in the sense that keep an eye on them, because they have an arrhythmia, it could turn poor. If they're symptomatic, you have to then consider, are they stable? Now, stability is fairly complicated because there are no concrete definitions of stability. If you say someone is stable, they are stable. What that means is that you've got time to stay in play. You have time to get an IV if you need one, to call down to pharmacy to get the medication up at the bedside. You're not cracking the code card. They're not dead. You've got time. Unstable, on the other hand, means that they are going to die in the next few minutes unless you do something. The big difference between stable and unstable is how you treat them. Now, you decide stability, but in ACLS, there's a couple of things that help you along the way. So as you begin, what you're going to look for instability, there's someone who's unstable, there's going to be a systolic blood pressure, less than 90, chest pain, shortness of breath, or altered mental status that occurs with the onset of the arrhythmia makes them unstable. If they're unstable, you have to fix them immediately. To do that, you use electricity. Fast equals shock. Slow equals pace. Now, shock here means synchronized cardioversion. Synchronized cardioversion means you push the sync button. What the sync button does is looks for a QRS complex in a T wave and will not drop the charge on a T wave. You can't tell the difference, it's milliseconds, but the machine can. So if you drop a QRS complex, that is, you discharge the machine on a T wave, Q1T phenomenon, they go into torsades and they die. So by pushing that button, you prevent that from happening. And because they have a rhythm, the machine will be able to identify a T wave. Fast shock, slow pace. If you decide they're stable, that is, they don't have systolic blood pressure less than 90, chest pain, shortness of breath, or altered mental status with the onset of the arrhythmia, now you have time to get some drugs. Now notice this entire time, the only rhythm you had to identify was normal sinus rhythm. Normal sinus or normal sinus a little quick. I haven't asked you to do any of that yet, and still I don't. For unstable, you only had one choice to make. Is it fast or is it slow? For stable, now you have to decide not only is it fast or is it slow, You must now decide, is it wide QRS complex or narrow? And the idea being here is that fast and narrow is likely to be SVT, and fast and wide is likely to be VTAC. Fast and wide gets amio. Fast and narrow gets adenosine. And slow rhythms get atropine. Prepare to pace. Not once have you had to identify the rhythm, so you didn't have to do that at all. There is one rhythm that you should be able to identify, and that is AFib flutter. AFib flutter is going to be controlled with a couple of agents. The right answer on the test is going to be a beta blocker or a calcium channel blocker, either verapamil or diltiazem. The reason why I put DIG and amio up here is because I want you to know for the wards that if they have CHF, you have to avoid the beta blocker and the calcium channel blocker, because if they're an acute CHF exacerbation and you give them one of these things, you make it worse. So for the test and for no heart failure, you're going to give a beta blocker, a calcium channel blocker, if you identified AFib, A flutter. Work with me now. AFib, A flutter are fast and narrow. You've already decided this person is stable, otherwise you'd shock them. It takes about 5 minutes to give all 3 doses of adenosine, 6 milligrams followed by 12 milligrams followed by 12 milligrams. The next step, even in SVT, if the adenosine doesn't work, is to give them a beta blocker or a calcium channel blocker. So even if you totally bombed the rapid response, you missed the AFib entirely, you're going to get to the right answer eventually anyway. I want you to recognize, you have to choose between shock, pace, amioadenosine atropine, or AFib, A flutter treatment. 6 decisions you have to make, and it's pretty easy to get there even without knowing how to read an EKG. Of course, we'll teach you how to read an EKG in the ACLS rhythms lecture, but now you know how to handle this, and it should not be so daunting. The same is true for a code. That is someone who has no pulse. A code is based around 2 minutes of CPR. Then a pulse check, rhythm check, shock if indicated. 2 minutes of CPR, pulse check, rhythm check, shock if indicated. 2 minutes of CPR, check a pulse, check a rhythm, shock if indicated. And this cycle repeats over and over until you decide to stop. In a code, there are only 2 rhythms you have to worry about. That is VTAC, VFib, and then there's everything else, which is known as PEA, asystole. PEA is any rhythm, not VTAC, VFib, that has no pulse. Asystole is a flat line. And here's the thing. 2 minutes of CPR, 1 pulse check, 1 rhythm check, 1 shock if indicated. 2 minutes of CPR, 1 pulse check, 1 rhythm check, 1 shock if indicated. And on every 2 minutes of CPR, you do 1 drug. The difference between VTAC, VFib, and PEA asystole is that you can shock VTAC, VFib, but you cannot shock PEA asystole. And now certain people remember, oh, there's a vasopressor in there and an antiarrhythmic, and which one can I replace, or the second dose or the third dose? Keep it simple. For VTAC, VFib, you're going to alternate between epinephrine, E, A, and amio, epi, and amio, etc. In PEA asystole, it used to be epi and atropine, but now it is epi and absent. EA, epi, and absent. EA, EA, EA. In PEA asystole, all you need to do are compressions and give epi once every 2 cycles or 4 minutes. That's it. On your test, if there is the option to do CPR, that is going to be the right answer. CPR is always the right answer. And the only time you can shock someone in a code is VTAC, VFib. So hopefully you see that the number of medical decisions you have to make, the number of options you have to intervene, is incredibly low. So that when you see a code of rapid response run well, and everyone in the room is quiet, it's because the leader has asserted themselves as the leader. And if you keep these in your memory banks, you'll have the confidence of knowing that you know what to do because there aren't a whole lot of choices. That's ACLS in a nutshell.